Hi guys. Okay, we're going to be discussing fluid electrolytes and parenteral therapy, which is IV therapy. So our tonight's learning objectives, we're going to list types and uses of solution used in the IV management of the body. We're going to define the steps involved in IV administration of solutions or electrolytes. We're going to describe how to calculate use for established IV flow rates. We're going to compare and contrast the types of uses for electrolytes and explain signs and symptoms of electrolyte imbalances and discuss nursing assessments and interventions used in electrolyte therapy. So key terms I want you to know: electrolytes, those are electrically charged substance essential to normal cell function. Extravasation, that's escape of fluid from the blood vessel into the surrounding tissue. Fluid overload, that's conditions where fluid intake exceeds elimination rate. Infiltration, that's the collection of fluid into tissue due to IV misplacement. And parenteral therapy, which is administration of fluids and medications via IV. So the different types of IV solution, we have our crystalloids, which are our normal saline, are isotonic. They maintain fluid balance. They are equal to a red blood cell. Hypotonic, they are used to hydrate our cells. Our cells are dry and it plumps them up. And then we have our hypertonic, and it pulls fluid from the cell, out of the cell, and that is our D10, our dextrose, our 3% hypertonic solution, our D5NS. Um, those are those different types of fluids. Then we have our colloids, which are our albumin, and this is they expand our intravascular volume. And then we have our TPN, which is nutrient-rich IV solution for our patients who cannot eat. So let's talk our common electrolytes and their function. So first one I want to talk about sodium. Sodium is for fluid balance and nerve function. So someone who has issues with sodium levels can be at risk for seizures or dehydration or fluid overload. So our normal sodium ranges are between 135 and 145. If someone is hyponatremic, that means they have low sodium. If someone is hypernatremic, they are too salty. Hypernatremic salty, that means they're fried, they are dry. We want to give them fluids to help dilute them because they have too much sodium. They're too salty. If they are hyponatremic, they have too much fluid. They don't have enough salt. So then we put them on a fluid restriction. Potassium, 3.5 to 5. Potassium regulates heart and muscle function. Heart is the muscle, the main muscle we want to think here. We never give IV potassium IV push. You never push it. It is given 10 milliequivalents an hour in a peripheral IV, and you better make sure you are on cardiac monitoring. So any irregular potassium levels can cause deadly arrhythmias. We never IV push. We never IV push. We never IV push. You can kill your patient. Calcium, that is for bone health. So calcium is very good for our bones, and it is important for us with our bone health because it can cause osteoporosis. Calcium ranges between 8.5 to 10.5, and when you give calcium supplements like Boniva, you want to make sure your patient is sitting in an upright position for at least 30 minutes because it can cause some burning of the esophagus. This is also good for muscle contractions. You want to make sure that your patient has a good potassium level. Now, moving on to magnesium is very important for our neurological nerve transmission. A normal mag level is between 1.7 and 2.2. If you have too high of a magnesium level, it can make you have decreased reflexes. If you have too low of a magnesium level, you can have seizures. So we want to keep our mag levels right in within limits. Now, as an LPN, you will replace electrolytes on the floor if you choose to work in a hospital. If your magnesium is low and your potassium is low, give mag first, and then your potassium. Potassium follows mag. Then you have your bicarbonate. These are your pH balancers, your acid-base agents, such as your bicarbonate. And so bicarb is important when your patient is acidic and it's a kidney issue. So you remember we talked about kidneys versus lungs, metabolic versus respiratory. And we use bicarbonate a lot to help our patients with issues such as kidney metabolic acidosis. So, sodium bicarbonate, like I told you, treats metabolic acidosis. This is for our patients who have kidney issues that retain the acid and cannot fix it, such as our patients who are in diabetic ketoacidosis. It's a kidney issue and they're retaining. Potassium chloride, KCl, this treats hypokalemia. If you have hyperkalemia, you use things such as a binder like Localma or Kayexalate. Calcium gluconate, that's used for hypocalcemia. And then mag sulfate, that treats hypomagnesemia or preeclampsia. Why are these medications used? Well, we use it to help correct our imbalances and prevent complication. We want to make sure we have a stable cardiac and neuromuscular function. And then we also need to make sure that we're watching for dehydration, but we have to be careful because we can accidentally overhydrate. So we can cause fluid volume overload. So be careful when giving these different medications. So bicarb, we can make too much of a good thing can cause an alkalosis. So we can buffer them too much and cause them to be alkaline. So you need to make sure you're watching your labs and you're notifying your physician. Potassium chloride, you've got to make sure that you are not overdoing it. You can cause hyperkalemia and that can cause those cardiac arrhythmias. So normally what we do is you have your standing orders, your electrolyte replacement protocol for your patients. And so you'll replace and then you'll do a potassium to check your potassium. Remember, we assess and we intervene and we evaluate. We always evaluate our intervention. Giving potassium is an intervention. Remember, medications are interventions as well as what we do with our hands. Calcium gluconate, too much can cause bradycardia and can also cause constipation. Remember, bradycardia is that slow heart rate. When it comes to messing with the heart, we got to be careful. And then magnesium, too much mag can cause hypotension. That's why it is also utilized in preeclampsia, because it can drop that blood pressure. But it can also cause respiratory depression. You've got to be careful. Remember those decreased reflexes. So as nurses, what do? We monitor our fluid imbalance. I-NOs. We better make sure what we're putting in is coming out. If not, we can cause fluid overload and we can drop the sodium. Assess electrolyte levels through our labs. Monitor for fluid overload and dehydration. We got to watch for both. Educate clients on dietary sources of electrolytes. Potassium, magnesium. Ensure correct IV administration rates. So when we are talking about it, again, a bag of potassium, a 1 liter bag of potassium can have as much as 40 milliequivalents all the way up to 80 milliequivalents. You would need to make sure that you are giving 10 milliequivalents an hour. So if 1,000 mils, if I have a bag of fluid that has 1,000 mils in it, and that 1,000 mils has 80 milliequivalents of potassium in it, you would want to check to see how much is in how many mils contains 10 milliequivalents, and then that's what you would give, ensure. And the pharmacy will send it up. It'll be in the order. A lot of times it's like 125 mils an hour, but you want to make sure you're safe when giving it. So remember safety, because again, at the end of the day, it is the nurse's responsibility to ensure that we are giving medication safely and appropriately. So some IV therapy safety concerns. You want to make sure you use proper technique to prevent infection. Remember, an IV is a direct pathway to the cardiovascular system. So you want to make sure you scrub the hub for 30 seconds. You want to make sure you're using everything has been covered or brand new. You want to make sure that you are using your Curos caps. Those are your chlorhexidine impregnated caps that you put on the hub. Before you put any medication into an IV, you always assess that IV site. I don't care if you've just given an antibiotic 30 minutes ago. You always assess that IV site. Some of those medications can burn through those IVs and cause an extravasation or an infiltrate. So you want to make sure, trust me, you do not want to dump potassium, magnesium, those electrolytes can be very caustic to the veins. You do not want to dump those into an infiltrated IV. That's very painful and it can cause skin necrosis. So you want to assess that IV site. How do we assess it? You take a 10 ml normal saline flush and you start to flush your IV. You're looking at the site of insertion and the skin around for redness, pain, or edema, some tightness in the skin. Again, follow institutional policies for IV administration. 10 milliequivalents an hour. And then educate your client. Make sure that they understand what to look for when these medications are going in. A lot of times I have noticed if you are open and honest with your patients, it's easier to get the job ddone. So that is my conclusion of fluid and electrolytes.